Great answer. Dr. Altia, I'll springboard off of that and just ask you more about what patients, going back to this all-comers kind of strategy, on next generation sequencing testing, for MTAP loss specifically, what should I, as the oncologist and or perhaps as the patient that is trying to be mindful of potential next treatment approaches that might be available to me, either with my oncogenic driven cancer and or non-oncogenic driven cancer, what should I be looking for on a molecular testing report that might show that I am a candidate for said MTAP loss trials?
Thank you for this question. So first of all, testing for MTAP is a bit difficult because until recently, not all panels included the MTAP gene in their genes that are tested. So until now, we had some panels that reported, for instance, CDKN2A loss, and we further tested based on that for MTAP because we know that in the majority, in many of the cases, in more than 90%, we can find an MTAP loss associated with the CDKN2A. But this is not a good proxy, and we need to include this gene in the panel for testing. Then there is another problem. For instance, we have two ways of testing with NGS, either the tissue, either the liquid biopsy. First of all, the liquid biopsy is not at all adequate for the MTAP loss detection because it's very limited in terms of the sensitivity to detect copy number deletions. Or even if a patient, for instance, has a high tumor burden, there is a very high shed of the ctDNA, circulating tumor DNA, there is a chance that the MTAP loss be identified, but it's really not the best technique to do. In terms of NGS, we can also miss MTAP detection if the tumor content from the biopsy is not high enough. The bioinformatic tools may miss it, and normally we need, and it's really dependent on the panel, but we might need tumor content as high as 40%. And when this tumor content is not adequate, we have another technique that can detect it, which is immunohistochemistry, where we need at least 100 cells present on the slide in order to be able to call this MTAP loss. And we need some kind of stroma to be sure that it's not an artifact and to see the positive internal control. And once this testing is positive for the MTAP loss, we can, of course, guide the patient towards clinical trials. If there is a patient with a targeted driver, an oncogene driver, we would favor first its targeted therapy, and then these inhibitors that currently are developed as monotherapy, but soon are starting to develop in combination with targeted agents.
So it sounds much more complicated than just a straightforward answer if there are many ways to test for this kind of alteration.